Given a patient with HAP and VAP, we design appropriate empiric therapy, and given microbiological results, we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated a patient's clinical stability to determine if antibiotic could be switched from IV to PO. Now, let's recommend an appropriate duration of therapy for HAP or VAP. Now, prior to the 2016 IDSA guideline for HAP and VAP, it was usually the question of whether we should treat for 1 or 2 weeks when it comes to VAP and HAP patients. And it was primarily due to the NUME study, which was published in JAMA in 2003, which looked at 8 days of treatment versus 15 days of treatment. And what they found was that there was actually no difference in mortality between the two groups, whether the patient received 8 days of treatment or 15 days of treatment. However, when they did subgroup analysis, in the group of patients who had VAP due to non-lactose fermenting organisms such as Pseudomonas and Acinetobacter, there was increased recurrent infection in the group of patients who received 8 days of treatment. And because of that, we started to treat patients who had VAP due to Pseudomonas or Acinetobacter for 14 days. Now, things started to heat up when a Cochrane review in 2015 compared short-term therapy to long-term therapy in patients with HAP and VAP, and found that in a group of patients who actually got short course of antibiotics for, let's say, 7 or 8 days, there was actually increased 28-day antibiotic-free days and reduced recurrent VAP due to multi-drug resistant pathogen. In other words, patients who had longer duration of therapy, they actually had more multi-drug resistant pathogens. In addition, there was no difference in mortality, recurrent pneumonia, treatment failure, or hospital length of stay when you compare the two groups. And they did still find that in group of patients who had Pseudomonas Acinetobacter, short course of antibiotics were associated with recurrent infection, but no other differences. So while these patients had the recurrent infection, those recurrent infections were less likely to be due to multi-drug resistant pathogens. So they were easy to treat. Whereas patients who had longer duration of treatment, while they were less likely to have recurrent infections, those recurrent infections were more likely to be multi-drug resistant. There was also a study published in Chest that showed that short course regimen compared to long course therapy was not associated with any difference in mortality, recurrent pneumonia, ventilator-free days, or duration of mechanical ventilation, or length of ICU. So what happened in 2016 when the IDSA guideline came out is that the panel actually did their own systematic review and meta-analysis, and they found that the specific subpopulation with VAP2 to non-glucose fermenting gram-negative organism was analyzed, and no difference was observed for pneumonia recurrence. So here's what the IDSA guideline recommends for length of therapy of VAP. They actually recommend a 7-day course of antimicrobial therapy rather than a longer duration. However, this recommendation is not to replace clinical judgment. So there may be situations in which a shorter or longer duration of antibiotic may be indicated, depending on whether the patient is clinically improving or deteriorating based on radiologic and laboratory parameters. But for most patients, 7 days of antibiotics is likely sufficient. And we can extrapolate from the VAP evidence and make basically the same recommendation for patients with HAP. So also for HAP, the guideline recommends 7-day course of antimicrobial therapy, but this is not to replace clinical judgment.